Good morning, everybody. Thank you, Professor Friedman. Thank you for CANSA. Can you hear me? Thank you for CANSA for the invitation to speak here today. Trying to do research on South African surveillance, it was rather difficult. Now, I don't know about you, but the first picture most of us think of when we think of surveillance is perhaps the WHO pictures, as you've seen from the two previous speakers. So now, if you look at these, every single one so far shown today had different figures for South Africa. So what is the role of surveillance? Surveillance needs a high quality surveillance can be delineated variations in disease incidence, mortality, and survival rates among populations or geographic regions, and alert us to areas in need of increased attention and research. So from that we can deduct that surveillance is very important both for preparation as well as for research. So who does surveillance? I think the one that springs to mind once again is the WHO, with the International Agency for Research on Cancer, IOC. In the United States, there are various entities doing surveillance. I've just listed a couple here. This Certified Tumor Registrar, the National Cancer Database. Then there's Surveillance, Epidemiology and End Results, the SEERS program. And in South Africa, we have, and it has been referred to a couple of times already today, is the National Cancer Registry. Have a look at all these figures. I've just taken some of the incidence and mortality rates as provided by GloboCan. And you will see here women, all ages, breast, colon, rectum cancer, and then cervical cancer. Both the incidence and the mortality rate. From the same site, we now have a look at women in Africa. And here you see primarily, again, breast and then cervical cancer. Now this is different rate. This is per 100,000. And here they say the incidence is 25 per 100,000 in Africa. That's not what we've seen before. So I'm getting a little bit concerned about how accurate is South Africa or African data that we are referring to. This one also from the WHO. It says here, Southern African Republic. Now, difficult to interpret whether this is just South Africa or the Southern African, but if you just think about it, it shows here that there are about 85,000 cervical cancer diagnosed, the incidence. That cannot just be South Africa. So I think this should include, as we've seen in the previous speaker's presentation, Swaziland, Lesotho, and all the southern regions of Africa. So let's get back to the National Cancer Registry. What we have at the moment is that the National Cancer Registry's data is fairly outdated. Now, I know 2001 has been made available already. 2002 data is ready for editing and should, according to my communication with the people at the NCR, will be ready for publishing towards the end of the year. As you can then figure out, there's approximately a 9-year delay in data coming out, which in the age of HIV is really inefficient for us to use for anything concrete. It's a good guide to look back on, but if you want to plan, there's just no ways that data is accurate enough. Also, we have to look at that, or think about and keep in mind that the National Cancer Registry is histological-based proven cases. That doesn't mean it's every single cancer that has been seen by a physician, gynecologist, or oncologist. Records of these are only the ones that have had histology. I'll show you some statistics that we have found in the laboratories of cases that have not had either histology yet or perhaps have already passed on and never had histology. So another area where disease is reported, cancer is reported, is the MRC, Burden of Disease Unit. And already there, Professor Albert here has shown that there's a big difference between the reported cases from mortality rates versus what is in the registry. The registry took a knock, if I can put it that way, when patient confidentiality became an issue. And they were then not supplied with all the information. Once again, you've got to understand the way the registry works. They actually work on a patient name, initial, birth date, if there is an ID number. So if they get a report, say, from hematology laboratory, which they then have to correlate with a histopathology at some stage, they need identifiers. They need patient identifications to work with. And when I spoke to them, I said, well, don't you insist on the ID numbers? And they say, no, it would be so nice if we can all use the ID numbers. It would make life much easier. So once again, there's one area that maybe patients are not being linked with the histologies because they are not identifiable as the same patient when they get the histologies. Remember, a lot of laboratory tests are done in the rural areas, and then they have perhaps their oncology treatment at the hospital, where they will have a biopsy or LETs or whatever. Now they have another hospital number. So how are you now going to link those two hospital numbers? And often patients come to a clinic and they use their maiden name, or they were married in the meantime, now they use their married name. I've seen records where the surname is actually transposed and the name is used. In other words, her name is used as a surname. So it's very difficult, these things, and we need to look at that. I have some statistics from the NCR. Please don't ask me what year. This is not published yet, so you know what it is. If you look at this, there's about 5,000 cervical cancers on the registry. And for the uterine cancers, there's just under 1,000. I've left out the ovaries from the simple reason is that we as cytologists do not actually see a lot of cancers that are from the ovaries, so I would not have any statistics on them once I go to the National Health Laboratory Services statistics. We are seeing increasingly vulva and vaginal cancers in cytology. So you will also notice that my stats refer to gynecological cancers or malignancies, not cervical cancers right through.